Good morning, everyone. Thank you for being on. This is our last day of our program. I know you've been with us for about 2 weeks, and we've heard from about 30 different speakers. So we're going to finish up with a couple speakers today, then we're going to do a drawing. So a few reminders, please put your full name and your Zoom profile so I can take attendance. We ask that you have your cameras on while our speakers are talking. And please be respectful of everyone on the call. And if you have questions, use the raise hand function or the chat function, and we'll call on you time permitting. So I'd like to introduce Dr. Dina Drake. She has been a palliative care clinical nurse specialist at Sharp Chula Vista Medical Center since 2019. So please welcome Dr. Drake.
Hi, thanks for inviting me. Before I get into sort of my nursing career, I just wanted to tell you a little bit about myself. I think like maybe a lot of you, growing up, I had a desire to help people. And when I was very young, I thought I would be a doctor. I wanted to be a physician. And life didn't really work out in the way I had planned. None of my family had ever gone to college. In fact, neither of my grandparents had finished high school, probably because of World War II. They went into the military. And so I got off track. And so I ended up in a different field entirely. I'm just trying to make my way as a young person. In fact, I ended up working for Marvel Comics for a while in my 20s. I ended up being the director of sales and marketing, which was really cool, but it was very corporate too. And I kind of felt a calling to do something else and decided that I would become an EMT paramedic. And not sure exactly why. I thought it would be a good stepping stone into healthcare and helping people. And I was a EMT and paramedic in Oakland for a while, Oakland, California. And one of the things that I enjoyed most as a paramedic and EMT was actually spending time with the patients. And I always wanted to know what happened to them afterwards, if they made it. Did they get better? Did they go home? And so I went to nursing school. I consider myself the nursiest of nurses. I have 4 nursing degrees and a postgraduate certificate. So I've been through 5 nursing programs since I went back to school for a nursing degree. A little bit about my personal life. I'm married. I have 2 cats. I have no children. The cats take up enough of my time. I teach a Japanese martial art called Aikido. I've been doing that for over 30 years. So it kind of coincides with my interest in healthcare. And they're actually very good balance for me, having this Aikido community and this physical practice, as well as this very intense practice of taking care of people who are either critically ill or at end of life. So when I first graduated from nursing school, I got a position as a new grad in a medical ICU in San Diego County at an academic facility, and learned a lot. But one of the first things I learned after starting my nursing career is that we weren't taught a lot about how to take care of people at end of life, how that was going to feel for us. As healthcare providers, especially nurses who are providing the majority of the care and at the bedside with the person who might be dying and their family, I felt very unprepared for that. So the very first conference I ever went to as an ICU nurse was actually a conference on end-of-life care, because I felt so ill-prepared and didn't know what to say to families whose loved one was dying. Wasn't very comfortable with it at all. I was an ICU nurse for about 5 years before I decided to go back and get a master's degree. And I decided to become a clinical nurse specialist rather than a nurse practitioner at that time because I really wanted to stay in the hospital setting, improving care to ICU patients and to improve end of life care to to patients and the care that and their families as well. I became an ICU and emergency department critical care and emergency department clinical nurse specialist. Did that for 6 years, and while I was doing that, I also went back for my doctoral degree. And it's a nursing research degree. The topic of my doctoral research was on improving end-of-life care to patients in the ICU and to their families. And right after I finished my PhD, I interviewed for a position here at Sharp Chula Vista for the ICU CNS position, clinical nurse specialist position. And they already had a candidate that they really wanted. And so they created a position for me because as a clinical nurse specialist in palliative care, because I had such a strong passion for the work. So I got to do that all throughout the pandemic. And I went back and got a postgraduate degree. I am now a board certified adult gerontology acute care practitioner. So I do work as a clinical nurse specialist, but the way that my role is operationalized is essentially as a nurse practitioner. I evaluate patients, I meet with their families, I place orders for symptom management, or if they're at end of life, for end of life orders. So that's kind of my history in a nutshell, a big nutshell. It's a long history. I'm not that young. But one thing I do want to say about education for those of you who are, I believe you're all in high school, is that because none of my family had gone to college and only a few of them had actually finished high school, I really questioned whether I could, if I had what it took to go on and pursue a master's degree and a doctorate. And I didn't think I was smart enough. I was. But what I found is you don't have to be brilliant. You don't have to be Albert Einstein to get through a doctoral program or a master's degree. What you need is persistence and a strong work ethic. So if any of you are questioning whether or not you can get through a master's degree or doctorate, if you want to become a nurse or a physician or pharmacist or physical therapist and get through a doctoral program, I promise you it's possible. And I'm sure you're all very bright because you're interested in going into this field anyway. So it just is a lot of work and a lot of persistence. So one of the things we want to talk about is, of course, the difference between palliative care and hospice. And I think this is a really important distinction because a lot of people think they're the same thing. So I'm a palliative care clinical nurse specialist. I'm not a hospice nurse. I'm not a hospice NP. I work in a hospital setting, and I've always worked in a hospital setting. I've never worked in an outpatient setting as a nurse. So palliative essentially means non-curative. So a lot of disease processes, diabetes, for instance, heart failure, the medications that are prescribed, insulin, Lasix to remove fluid from somebody, those aren't curative medications. Those are palliative medications in a way. Without them, the person's symptoms would become overwhelming pretty quickly, especially with heart failure. They might become short of breath, or their legs might swell up. And with diabetes, you might end up in a state of very high elevated blood sugar and lose consciousness. And so these medications manage those diseases. And for palliative medicine, we're attempting to manage symptoms. And sometimes it's for people who are near the end of their life and no longer seeking any curative treatment, like if they have a terminal cancer diagnosis. But we can also manage symptoms for people who are still seeking curative treatment for cancer. Maybe they have really bad pain or nausea, vomiting, anxiety, poor appetite, any list of symptoms you can think of that might be related to either their cancer or side effects from the treatment they're getting, chemotherapy, radiation, immunotherapy. And um, research has been shown that shows that people who receive palliative treatment while they're pursuing curative treatment for their cancer actually manage better and sometimes live longer because if they feel better, if their appetite's good, if their nausea and vomiting's controlled, if their pain is controlled, their quality of life is better and they're more apt to be able to continue those treatments if the side effects are well managed. And so in the difference between hospice and palliative is by the time someone's symptom management has become the priority and the focus of care, um, and they've moved away from curative treatment, it's time for hospice. The hospice includes palliative treatment, but the hospice uh, program is interdisciplinary in nature and it looks at the whole person, including their family. So it's their physical needs are addressed, but so are their psychosocial needs, their spiritual care needs, and the family is supported. The majority of hospice care happens in the home, but there are hospice locations, hospice homes, specifically for people who are near the end of their life. And their hospice can be provided in skilled nursing facilities as well. But, the majority of people in America, at least 75% say they want to pass away at home. And so, and they want to be with their family, of course. And that makes sense. If you're in your final days, weeks of life, most people don't want a lot of strangers around them. They want to be with their family. They want to be with the people who are most important to them. And they want to minimize intrusions into their daily life at that point. So, a person at home on hospice would normally be seen by a nurse at least once or twice a week, depending on the symptoms and how well they're managed. They could have a nursing assistant come out twice a week, 3 times a week to help with personal care. If a person doesn't need a lot of assistance, maybe they'll come out and just do massages on their feet or their shoulders, whatever. A social worker also comes out weekly to assess any need for resources. Maybe they need assistance trying to find uh, or find mortuaries for final arrangements, but it could also be applying for certain benefits like IHSS hours, which is paid caregiver hours in the home. And then a chaplain will also come out weekly as well to provide emotional and spiritual support to the family and the patient. Because a lot of things come up for people at end of life, especially if there's any estranged family members or broken relationships or things that a person feels like maybe they have left undone. And that can bring up a lot of angst and actually increase somebody's symptoms if they have a lot of unresolved issues with family. And so it's a very comprehensive program. It's meant to manage the person's care in the home, but most of the care is provided by the family. And the nurse and the nurse's aide do a lot of education with family to help them understand when, how to assess for pain, how to assess for other symptoms, and how to administer medications. Hospice also provides the medications that a person would need for managing symptoms in the home, as well as any equipment they might need. So if a person has become um, so debilitated that they're unable to get out of bed, that would include something like a hospital bed. It may include things for personal care like a diaper. It may include a walker if they're still ambulatory, oxygen if they need it, because they're short of breath, and a lot of different other equipment just to make sure that they're safe, and they're in terms of ambulation and mobility, but also just for their care in general. So they get a lot of extra equipment. Um, I think I talked about that. So one thing I do want to say is that, the the current trend is that a lot of people go to the hospital, and a lot of them pass away there. Um, During the COVID pandemic, those were very high, obviously, and they were very high at my hospital. I would say the majority of people admitted to the ICU did not survive the hospitalization. A lot of people on the lower level of care floors also did not survive the hospitalization if the COVID was very severe. Um, but prior to the 1920s, most people got care in their home, and the idea of a hospital, where you went to go get care, was actually pretty rare, and they only became widespread in the late 1860s, and the number has actually remained pretty much the same, around 6,000 acute care hospitals in the United States since the 1930s. And where care mostly happened prior to that was in the home, and you would pay a physician to come to the home. Hospitals were thought of places that almost like asylums, which is interesting because hospicio in Spanish, when I talk to my Spanish speaking patients and families, sometimes when I say hospicio, um, their understanding of that is an asylum. So they think it's a place where somebody goes and not a set of services that are provided in the home. So I have to be very clear with them that we're not talking about sending somebody to an asylum. But that's kind of how hospitals were thought of. That's where the poor people went, and it was a bad place, and you'd probably get sicker if you went there. So the majority of people in the United States and probably worldwide prior to the 1930s passed away at home, and it was something that we were a lot more comfortable with. Um, Now we are not comfortable with end of life care. Um, Even I, as a ICU nurse at the time, caring for my mother at the end of her life, um, I got nervous. I got overwhelmed because it was my mother. Even though I'd cared for many people at end of life prior to her passing, it was really different. So, it's always going to be an emotional experience when somebody you love passes away. Um, but now the shift is this shift away from people passing away at home, and people being exposed to that, perhaps from even a pretty young age, has made us even more uncomfortable with it and frightened of it. So I guess maybe I can ask you some questions. Has anybody had experience with a loved one or family member dying? And you guys are young, so I hope there's not many of you, but has anybody had experience with a loved one passing away? And I can't see all of you. Looks like no.
We
Oh,
have a
your
couple
grandpa.
in the chat. Yeah.
Yes, a couple of you.
Yeah.
Um, and did you, for Aaron or Jillian, um, how did that impact you? I mean, were you getting a lot of support? Were they at home? Were they in a hospital setting? If you don't mind my asking, I don't put you on the spot.
Um, Hi, it's Jillian. So
Hi.
so sorry I can't be on camera today, but when I had a loved one pass away, it was I don't remember where my grandfather was exactly at the time. But I just remember because I was a few years younger and it was really hard for the family. But at the same time, it wasn't as bad as I know as it could be for some other people because he actually lived to be 100. So he
Wow.
lived a pretty long life, which I'm grateful
Mhm.
for.
Yeah. Wow. So it sounds like he may have passed away naturally from essentially his age.
Yes, I can't remember the exact cause actually.
Yeah. That's another thing that I've noticed. And if you're going into healthcare, and I expect you're interested in it, we're not very used to the idea of a natural death anymore. Um, I go to the emergency department a lot in my hospital. The emergency department physicians contact me, and they'll tell me when they contact me, this person is dying. They're actively dying, meaning they've got hours to minutes, maybe days, and they haven't told the family that yet. And when I get to the bedside and I look at this person and on a gurney in an emergency department, what a horrible place for someone to be at the end of their life on a gurney in a crowded emergency department. I see somebody who is oftentimes near the end of their natural life. And sometimes just telling people or asking people, can I tell you, can I share with you what I'm seeing? And letting them know, you know, mom is 94 years old and she looks like she's getting close to the end of her natural life here. Where do you think she would want to be? And that can really reframe that conversation very quickly from let's jump into action and do a lot of things to them to, and I mean to them, not for them, to them at that point, because they are actively dying, um, to really focusing on like how best can we support you and make this your mom's passing peaceful and dignified. And that's the goal of hospice. And that's the goal of my team, the palliative care team in the hospital, to talk with people about these decisions, about whether to seek curative treatment or interventions like dialysis, a surgical procedure that may be very risky or high risk for somebody, and the possibility of a poor outcome is very high. Things like intubation and being placed on a ventilator, or other forms of life support, and then ultimately things like resuscitation. Most people don't, and I do want to share with you, I know we don't have more time, but I do want to share with you that unlike what's depicted in movies or on television, um, only about 10% of people who undergo out of hospital resuscitation, CPR resuscitation, survive to discharge. Less than 10%. And most people have no idea. Most people think that that number is around 3 out of 4, 75%. So if you perform CPR on somebody, they're going to get better. Sometimes they'll just wake up and they'll be okay. And that's what happens in the movies. But I don't know if any of you remember the football player who got hit in the chest a few years ago, and had a cardiac arrest due to the impact on his heart and went into a lethal cardiac rhythm. And that guy, who was a 25-year-old athlete, was on life support for a week. He was a 25-year-old athlete who didn't have a real reason, like any sort of medical condition or disease process going on, but was actually just hit in the chest. And so, elderly folks with a lot of medical conditions they might be resuscitated for a short period of time, but they likely will not survive to discharge. And if they do survive, they'll likely have either functional or cognitive deficits, because of that cardiac arrest, the decreased blood flow and oxygen to the brain and the other organs during that resuscitation period. So I just point that out because you have families, you all, and this is something that I think a lot of people don't know about resuscitation attempts. So I only bring it up because it's my job to share education about this stuff with everybody, even high school students. So do you guys have any questions? Because we just have a few minutes left, I think. Am I right, Sierra?
Yes, we have a few minutes. Yes. Our next speaker isn't on until a little bit later. So yeah, we
Okay.
can take questions.
Do you guys have any questions about my work? It's rough work, by the way. I just want to say it's very emotional. And I think that when I took this position in 2019, I thought I would stay in this position until I retired. I thought it was going to be a 15-year, 20-year career for me. And the pandemic really probably cut that short by about 10 years because it was so emotionally draining, having to deal with 10 to 15 of my patients dying every single day in this hospital from COVID for months. And so it's rewarding work, but it's also very emotionally challenging work. How many patients do I tend to at a time? You can't see this. Here's my list. It normally it really fluctuates. Sometimes when the hospital is very full and we have a lot of sick patients, sometimes the physicians will actually put in referrals to our teams to go and talk to them about their their cancer, their heart failure, their COPD, whatever disease process that they have that's chronic, that's going to be chronic and progressive, like heart failure, kidney disease, cancer. Generally, I try to, I normally see in between 7 to 10 patients a day. I am pretty efficient and I walk very fast. But reviewing the charts, going to talk to the patient, really having a good idea of what's going on with them so I can talk about the disease progression of their specific disease and treatment options, finding out what's important to them. And those meetings can take an hour, sometimes longer, hopefully no more than an hour, but an entire patient from going through the chart, meeting with them, having that kind of conversation to charting is probably around an hour and a half per person. So 8 to 10 patients is a lot. But that's, on our list because we're a team, anywhere from 20 to 30 patients daily our team is seeing. How big is a hospice team? So our palliative care team in the hospital we have 4.5 FTEs. So 4 advanced practice nurses, myself and 3 other NPs, and we have a social worker who's half-time. Out in the field, a hospice team, like I said, is going to include a medical director, a nurse, a chaplain, social worker, and a nursing assistant. Some hospice have respiratory therapists as well if they have respiratory issues, and they also evaluate the patients, especially if they have like pulmonary fibrosis or cystic fibrosis, something like that, that really impacts the lung. Jillian, I see you have your hand up.
Hello. So I was wondering, have you ever had to take a day off because a particular patient or a particular day was just really emotionally draining for you?
That's a really good question. Usually not. I try to set sort of emotional boundaries. Obviously, there's been some cases that have been pretty hard. During COVID, during the worst part of COVID, which was the winter of 2020, we had a smaller team then, and my colleague and I were seeing 45 to 50 patients a day between the two of us, and almost all of them were dying in some stage of dying. And it was very hard to get their symptoms under control. They were suffering. Family couldn't come in, so we were calling families a lot. Eventually, that took a huge toll on my physical health and my psychological health, and I ended up taking 3 weeks off, which is the longest I've ever taken off in my entire life. But I couldn't eat at work anymore because it was so stressful and I was running from one dying patient to another that I couldn't eat, I couldn't drink, I could hardly sleep. I had almost PTSD from images of people dying all over the hospital. It was a very hard time in the hospital, especially in this hospital. The two South Bay hospitals in San Diego pretty much became overwhelmed with COVID patients by late April of 2020. And that continued through the Omicron wave. So 2022. So it was a long time to be working 16, 17-hour days with, you know, half a dozen of your patients dying every day. So the best thing to do when you have to do that is really learn to set boundaries and take care of yourself. And I wasn't good at that then. I'm much better at it now because I'm never going to let myself get to a point like that where I'm not taking care of myself and I'm actually becoming physically ill from not eating and drinking and sleeping. What kind of day? That's a really good question. My job is really rewarding. That was the bleak period of the darkest part of the pandemic, right? I just saw a patient who has very advanced cancer, and she and her husband live in Idaho, and we were able to get her stabilized, get her pain under control, and she's going home to Idaho today. And that makes me happy that I can find out what a person's goal is, what they really want, for however much time they have left, if they're dying, especially. What do they want to do? Where do they want to be? And if I can help them achieve those goals, that makes me really happy. Like I've done my job. And sometimes patients' goals are not necessarily what the doctors think that they should be doing, right? Some physicians might think, well, they should go on hospice right now here, and we shouldn't be treating them. Their cancer's too advanced. And this person really wants to go home. You know, the majority of their family, they have this beautiful house, their faith community's there, their friends are there. And so what the physician thinks and what the person thinks about like what should be important and what we should be doing are very different. And when I can help the patient and their family achieve those goals, like I've done my job. I've done my job. It makes me really happy. Who helped me along the way? Millions of people. First of all, my grandmother. I was raised partially by my grandparents, and my grandmother only went through her freshman year in high school. She had to leave high school to help her parents during World War II. And she was always encouraging. Even though she hardly had any money, she helped me pay for my college textbooks back when they were like still $30 or $40 instead of $250 and $275 a pop. So she was my biggest cheerleader, my biggest support. You know, there have been really fantastic physicians that I've worked with who have always encouraged me to go back to school to get more advanced degrees. Here at this organization, I would say the nursing leadership here is very, very encouraging and supportive of nurses who want to go back for a master's degree, a doctoral degree. And the organization has really good support for continuing education and educational funds. But I think also my spouse, obviously, putting up with me being in school on and off for the last 25 years has been rough, right? Just when I slow down for a little bit and I have some free time, I'm like, maybe I'll start another postgraduate program. And that's no longer an option. I've done my 5. I'm the nursiest of nurses. I'm not going to do any more. Or that's what I said earlier this year. You never know. I love learning. Believe in yourself and your ability to pursue a career in medicine, whether it is becoming a physician, becoming a respiratory therapist, becoming a nurse, becoming a pharmacist, physical therapist, speech therapist. I do think that if the work is tough and the environment, healthcare in the United States can feel a little fractured. It is a little bit fractured. We could do a lot better with continuity of care and transitions between being in a hospital and home and a nursing facility. So I hope you're doing it because you have a passion for it. If you don't have a passion for what you're doing, sometimes the burdens of the work and getting frustrated with some of the things that are kind of broken, like in these transitions of care, they will become so frustrating that it can really impact your work. But if you love what you do and you feel a calling for it, I think that will carry you through some of those times that are more difficult, and help, maybe help you overlook some of these things, or at least look for ways to improve the processes or these care systems so that they work better for the people in our communities. I hope that answered that question.
No, this was
Yeah.
great. Yeah.
Yeah.
And does anybody else have any questions before we move to the next thing? Thank you, Dr. Drake. This was a really great overview. You are the nursiest of nurses.
Yeah, I totally am the nurse. Five of them. I like to say that too, because some people think they see the PhD and they say, "Oh, Dr. Drake," and I said, "Well, I'm not a physician. I'm a nurse with a doctorate, but I have 5 nursing degrees. So please, I'm like the nursiest of nurses. Just realize that." So,
Well, that's wonderful. Well,
good
thank
luck
you
to
so
all
much.
of you.
Yes,
Good luck
thank
to
you for
all of
your
you.
time.
All right. Take care.
All right.
Bye-bye.
Bye-bye. All right, guys, we're waiting for our next speaker to jump on. But what I wanted to do in the meantime was I was going to tell you a little bit about what I do. So I work at the Medical Society, and the Medical Society is a component society of the California Medical Association. So we are a membership association for physicians, and we're responsible for helping them with advocacy, and helping them with what they need in maybe their private practice, maybe if they need to hire someone or they need to get supplies. We're responsible for helping them if they need to get malpractice insurance, or they need legal help. So we work with the CMA. We work alongside them to help physicians with what they need and to fight for what will help them practice medicine the best in our state. So that's what the Medical Society does. The Medical Society also runs a nonprofit. I work for them as well. And the nonprofit organization has 5 programs. So we have a medical student scholarship fund that was started in the 1960s, and we give scholarships to those medical students that have a financial need that come from our region. We cover 3 counties where most of you come from Sacramento, El Dorado, and Yolo County. And what we do is we provide them with scholarships to help ease the burden of medical school, because obviously we know that it can be tens of thousands, if not hundreds of thousands of dollars to go to medical school. So, and any student that graduated from a high school in one of our counties, no matter where they go to medical school, is eligible for the scholarship. We also run the Sacramento County Opioid Coalition, and that's a coalition that looks at fentanyl and overdose prevention in Sacramento County and trying to reduce fentanyl overdoses. We give Narcan or naloxone out to the community. We give thousands out to the community every year. We do community events. We talk to high schools. We do all sorts of different community outreach to try to support the community that needs it the most. The other program that we run besides this program is our wellness program. So we run a wellness program for physicians, and that's where we offer mental health services. We offer different things like socials and peer groups where they can get together and talk about all the challenges that come along with being a physician and being in that physician world. We also run a summit every year where they get continuing medical education and they learn about wellness and about taking care of themselves so they can take care of their patients. We have our Spirit program. And this program is where we have some caseworkers and they work with physicians and hospital facilities that actually donate care to those that are uninsured. So a doctor would refer a patient to us to get, say, like a vision exam or a colonoscopy or some other type of procedure that they need that they don't have insurance to cover, and we would support them in getting that. So we have caseworkers that work with those patients and those hospital locations. And then lastly, we have our Future of Medicine program, which you're all part of, and that's what I run as well. And that program is a workforce development. We try to get opportunities for students to get into the hospital and into private practice and shadow doctors. We do this online program. We do outreach to schools. And what we're trying to do is inspire students like yourself to pick medicine, no matter what you choose. You don't have to be a doctor or a nurse. There are lots, as you have learned, different healthcare careers out there. And so we hope that maybe 1, 2, or more of these presentations over the last 2 weeks have given you a good idea as to something you might want to explore more. And if there is an area that we touched on, or even an area we didn't touch on that you want to learn more about, please reach out to me because I might be able to find somebody you can talk to in a field that you have more information about, so you can have more information about that career if that's something that you want to pursue. I'm also working on an opportunity. I'm hoping to offer the possibility of going into Sutter, the simulation lab. I'm trying to work that out, but if we do that, depending on how many slots we get, our online folks would get first dibs of that. So I'm hoping to work that out. So continue to check your email after this program because I'm hoping to work that out for something in July. So what we're going to do is our next speaker is going to be on at 11. If you have any questions for me about our role here at the Medical Society or what we do with doctors, please let me know. What are your working hours like? So I work at an office, just regular 9 to 5, Monday through Friday. There's occasional weekends. We have a museum of medical history here. The museum is on site, and so it's open during the week and some Saturdays in the summer. So I would work here at the museum as well. But my job and the job of our caseworkers and those that work in the advocacy world is going to be a regular working business hours, Monday through Friday. Any other questions for me? I'll talk about a little bit about education too. We have degrees in all sorts of things here. So some of them have degrees in communications. Some of them have degrees in different political type degrees if they're doing like advocacy. I have a degree in psychology. I was originally going to go to school to be a therapist and then kind of changed my trajectory. And then I was going to school to be a sign language interpreter. And then I found psychology and I thought that that would be really fun to do. And then I landed this job actually through the museum and I loved it. I loved working with doctors. I love working with students. I had worked in nonprofits prior to that. And so the nonprofit work was really where I found my passion. And so there's no specific degree that you need in order to work in this environment. Generally, you have a bachelor's degree, and a few of our staff members also have master's degrees. Several of our employees went back to school to get their master's in public health, which is a really, really good career to get if that's something that you're interested in working with health community health, and working with patients either through our Spirit program or working with the Opioid Coalition. A master's in public health is really, really helpful for that. So what I'm going to do is give you a little bit of a break. So go ahead and you can turn your cameras off. I'll give you 10 minutes. And so be back here at 10:55 and we'll move on to our next speaker. Okay, welcome back, everyone. And you see at least some of your cameras on, so I know you're back with us. There we go. All right. Thank you all. So we're going to move to our last speaker of the day before I have a few updates and we do the drawing. So you've already met him. So I want to welcome back Dr. Eric Williams. And Dr. Williams, if you remember, was the one we spoke with the very first day, and who kind of gave you a few things to think about. And he's going to talk a little bit about kind of what you've learned and sort of send you off with some well wishes and some words of advice as you continue your journey into medicine. So welcome, Dr. Williams.
Hi guys, thanks for coming back. Thanks for spending the last couple of weeks with us. I hope this has been very helpful and eye-opening for you. I probably have as many questions as you have at this point, and I see that as a very, very good thing. And I'll start off by really asking, what did you see that was unexpected? What experiences did you have that were the most unexpected and surprised you? If you can, just type it in, and while you're typing it, and I'll continue, and we'll come back to it. And the other thing I want you to put in there is, what would you like to have more of during this experience? Because what we are hoping to do is expose you to aspects of medicine so that you can answer the question of, yeah, I may want to do that and I want to really look into it further, or no, I don't. And our whole goal here was to let you answer that question of yes or no. Because as you can tell from all the individuals you met, medicine requires a tremendous amount of investment of your time, your commitment, and not the least, your money. And at the end of the day, those things are important. It is worth it if it's something you feel that suits who you are or who you are growing into. You're not there yet. You're still quite a ways from making that full commitment to medicine. And don't believe that at this point you make a decision that cannot be reversed. It can be. Medicine and what you do parallels many things. Did they have a chance to speak with, to hear from Dr. Chuck?
We did not get a chance to speak with Dr. Chuck.
Okay. Well, Dr. John Chuck is an amazing physician. He communicates very, very effectively, but one of the things I remember him saying, well, two things I will say, and was asked to me the first time I spoke to you, is that you must have life balance. You must have life balance. Those of you who decided that medicine was something you wanted to look further into, you're here because you are hard drivers. You push yourself. You are learners, and you will be lifelong learners. But having said that, you must have balance as well. It can't always be about study, study, study. Your patients will get the best out of you and benefit the most if you have balance. The second thing he would have told you about is ligers. I don't know how many of you know what a liger is. We refer to it as a combination of a lion and a tiger. And what he is trying to express there, and I hope I'm challenging Dr. Chuck really well, is that you are exposed to many people in your life, and it's not just your mother and your father or your uncle or your aunt, your older brother or your older sister, but other people who you will meet along the way who will influence you. And you take the best of each of these individuals, and you become that person. You let it become part of who you are. And you may ask questions, you may observe them much more closely to figure out what those qualities are that you want in you. And that's your LIGO. That's who you become. And I would be interested in knowing what you saw out there in various individuals that you would like to harness and become part of yourself. I hope that we were able to answer some of the questions for you about medicine. What do I take home with me? What do I leave at work that I isolate from my family? Because you will become that. As a surgeon, I laugh because I think about my wife and I doing things around the house, especially if we are doing something together. And I will ask for various items while she's there with me, helping. And she says, you know, Eric, you're not in the operating room. I'm not just gonna pass you this instrument or that instrument, but how can I help? It becomes part of who you are, and it can be a fun thing at times. I mentioned earlier that, in the last time I spoke to you, that you must find other outlets for your life. And Sam will tell you that I write poetry, I do photography. I enjoy meeting people. One of my best friends right now, she is probably 80. I met her at Starbucks, and we just sat down and talked. And this was, gosh, probably about 7 years ago. Yeah, and we still communicate. We talk at least once a week. She's in Sacramento, and really nice person. But feel free to reach out to people. Fill your life with people that gives you something to take home. It gives you a better view of life. It is not all about medicine. But I'm still making a great argument for medicine. So with that in mind, I have asked some questions. And I'm going to read some of your responses, or Sam will tell me some of the things that you asked. But now I'm going to give you 2 more. Do you think that a program such as this could have been introduced to you earlier in your school life? And did you see AI, the introduction of AI, being part of medicine? And how do you see it being introduced? This program is the future of medicine. And how do you see the future of medicine growing and going forward? Even if you can't comment on that right now, Sam will be sending out a survey that we hope will allow you to give us some feedback on that. It really makes a difference. We hear you. We want to hear from you because it's with your input that medicine moves forward. You are the future of medicine. You are who I was a number of years ago. Sam?
We have a couple of responses.
Okay.
So Jillian says, most surprising was discovering new professions that I never knew about. However, I also think this program helped me narrow what options I like.
Okay, that's good.
We have Sweetha that said, she said that a lot of professionals are able to keep priorities between life and work in pretty good balance, more than I thought. And then Ria says that it's okay not to succeed at the first time, and to continue to try and be perseverant and achieving in one's goals, even though it might take longer. Persevering, it is important because the end goal of changing others' lives. We have another one. I could see AI being used in charting, but I don't think it could replace hands-on treatment for now. And then Robin said the most interesting was learning about the job of the coroner technician. What I also noticed was that most common quality among the speakers was persistence. And I think this program would be helpful for middle schoolers in addition to high schoolers.
Thank you. Yeah.
And then, like Dr. Williams said, I'm going to be sending out a survey as well for you to put your thoughts into a little bit more deeply so that we can, and we want to follow you as well. We want to hear about your journey as you continue on beyond this program and you head into your adult lives and what you choose to do. We want you to stay in touch and share that with us.
One of probably the last thing I'm going to put out there is that medicine's a difficult field. You don't always have great outcomes. It's what we aim for. And even the good outcomes are sometimes difficult to go home and fall asleep on. And that includes the older patient who may decide, Doc, I know I won't survive this, but I don't want you to do anything for me. It might include the young child who's very sick, and at this point, with our present fund of knowledge, we cannot help. But we do have to allow patients their dignity and the parents their privacy and ability to make the best decision for themselves. And while we have the knowledge, we don't have the right to make those decisions for them, and we have to respect them. But we can then still have empathy and still give them the comfort that they need and the support and reassurance that we are going to do everything they can, and they will make that final decision. So listen, I'm glad you took the time. I'm glad you expressed the interest in medicine. You guys are the best of who we are now and going forward. Persistence is important. Perseverance is important. Stay with it. You may not succeed the first time. Some of you here have always succeeded the first time. And I compliment you for that. I applaud you for that. But you will run into challenges, and always recognize that the person next to you, the other people on the screen with you here now are there to support you. We have to do this as a team. On good days and bad days, look to your left and your right. It takes a team, and not everyone has MD behind their name.
All right. Okay. Well, that wraps up our speakers for the program. And so everyone, please thank Dr. Williams for jumping on the call at the end here and giving some wise words of advice. Thank you, Dr. Williams, for your time and, of course, for starting this program.
You're very welcome, guys. Take care, Sam. And guys, listen, Sam has been the coordinator of this program for all of these years, and she's done a tremendous job. You and I wouldn't be here with the ability to talk to each other right now, to have the speakers that we have had. She's made a huge difference, more than I could ever say. So please let her know that.
Thank you.
Okay, guys,
all right.
Take care now.
So the last couple of announcements. So I do have certificates that I'll send you. I'm going to send a survey out. As long as you attended 6 or more days, you'll get your certificate. And we do ask that you fill out the survey. And then after the survey is filled out, we'll send you your certificate. You can expect those early next week. The winners of our gift cards are Ritik Sangani, Kachin Arya, and Robin Peralta. you're our three $100 gift card winners. I also wanted to give a shout out to Jillian, who was always asking questions and very engaged. Thank you, Jillian. Thank you all for
Oh, thank
contributing
you.
and having your camera on. And we wish you the best, and we'll be in touch. So have a wonderful rest of your day.